Hello, my name is Dr. Chad Schaefer. I'm a physical therapist here in Metro Detroit. One of my biggest passions is working with patients that have TMD dysfunction and neck problems. So first off, I want to take this time to just say thank you for taking the time out of your day to watch some of these objectives in relation to patients that are suffering with TMD. So to give you a little bit of my background, so I'm a physical therapist, like I said, and my big specialty is neck pain, headaches, and TMJ dysfunction, and as well as upper thoracic and shoulder dysfunction, and this all plays a role in TMD dysfunction. So the one reason why I'm really interested in working with these patients and this patient population is because not a lot of physical therapists do, and I find that I have a lot of good success with patients with some of the techniques I do with patients and how they can ultimately self-manage these symptoms, because patients should be able to go home at the end of the day and be able to heal themselves and make themselves feel better. So that's the cool thing I like about this, is there's a population that's I think is underserved, and I think that we can do a lot of good, and I just want to spread the word and let everyone know about some of the things that we're doing. So in physical therapy, I want to talk about some of the objectives as far as a presentation to you guys. So the first thing that I want to bring up is really explain and understand the relationship between the TMJ joint, the TMJ, and the cervical spine or the neck. So in our field, if you guys are familiar with Dr. Rockabato's work and some of his research, he's a physical therapist or a physiotherapist out in Chile, and a lot of his research looked at, how is the neck related to the jaw joint? Is it not? What's going on there? And then what he found was with a prolonged, essentially forward head where you have lower cervical flexion or forward and an upper cervical extension, that's going to pull the jaw joint in a retruded or a backwards position, which is hypothesized to create some sort of dysfunction, possible pressure on the retrodiscal tissue. So that's one of the biggest things that I want to get in front of, whether it's a patient, a dentist, neurologist, that these things aren't just TMJ dysfunction. Like, it's not just the jaw. It's very, very complex as far as what's going on, how to fix it, what we think is going on, and what we should say to the patient ultimately. So the sub point of that too is in relation to the cervical spine and the jaw. It's also kind of a whole body experience. So in my practice, I'm working with patients. I progress them through jaw movements and do some hands-on techniques to get them calm down as far as their pain level, get their mechanics a little better, and then work on the upper thoracic spine as well as the shoulder joint as well, because we know that posture plays a big role in TMJ dysfunction. And if you can just expose patients, especially chronic patients, to movement, we know that one, movement's just great for you. Whether it's low back pain, shoulder pain, chronic neck pain, if you're not moving, it's probably feeling stiff, it's probably feeling painful, no good. I mean, we see patients every day whether it's neck pain, chronic lower back pain, especially with TMJ dysfunction. It's just important to get you moving. So whether patients benefit from a mechanical standpoint where you're saying the upper thoracic spine is related to the neck and the jaw, or if it's exposing patients and people to exercise that they probably haven't done for so long because they're at home depressed, they don't want to go out with their friends and family because they're scared of how their jaw is going to hurt. So that's the first objective that I'm really going to explain, and it's going to be a bit of a mechanical explanation. Then I'm going to link it to some of the chronic pain patients and how to help those people. The next one is going to be understanding a diagnostic classification in relation to, it's in physical therapy, but as it relates to TMD or TMJ dysfunction, I think that we kind of all need to be on the same page. So what I mean by a classification, is it considered an arthralgia? Is it more joint related? Is it muscle related? And what we find most often is it's a little bit of everything. But it's important to find out what's going on, what their movement looks like, if they've got clicking, popping, is there reduction, is there no reduction, what's their mouth opening look like, how's their deviation. One of the biggest things that I find with a lot of my patients is, especially if you're having pain with chewing, is if you have pain with chewing, you're usually lacking deviation on one side or the other, because with mastication, you got to kind of grind, you're not walking around like Pac-Man without any sort of medial lateral deviation. So that's one of the other points that I'm going to hit at, is understanding a diagnostic classification on what we think is going on in the research and what it looks like when you have an actual patient in front of you. So that leads to the next point, is describe the mechanics of the TMJ as well as common movement deviations. So the typical deviations that are out there are the C curve and the S curve, where a C curve is essentially you're deviating as soon as you open, goes to one side and comes back to the middle, where an S curve is as soon as you open, it's going to kind of deviate to one side you're going to get some sort of reduction or a click, and then you're going to come back to the middle. So I want to discuss some of those things, how they're treated differently, and how a lot of those, those two specific symptoms and conditions actually share some common treatment strategies. Meaning, if we have a C curve and an S curve, are we going to treat them differently? The answer is yes, but then we can kind of get the mechanics back and more normalized, and then you're going to see some commonalities as far as treatment for this. The next point is being able to describe and demonstrate a proper TMJ and cervical screen. So this is one of the big things that I love when I'm getting out in front of dentists and just the community in general is you have a patient in front of you, they've got jaw pain, what am I going to do? Am I going to create a night guard? Am I going to create a repositioning splint? What am I going to do with this patient in front of me? So on my end as a physical therapist, when we're looking at the mechanics, I don't do any imaging, x-rays, MRIs, injections. So it's one cool thing because it's really a holistic approach to finding relief for these patients. I really enjoy it because, again, like I said in the beginning, it's an underserved population, so I really like to work with these patients. And again, so proper TMJ and cervical evaluation, what is this going to look like? Meaning I want to guide you guys through kind of a mock evaluation of what we're looking at. A very, very simple way to screen, and because we're all busy, is just being able to move the jaw, being able to move the neck, looking for restrictions. So, for example, a person sitting in front of you, move your jaw. Does that hurt? Let's look at your medial lateral deviation. I'm sure you'll check their occlusion as a dentist. But the one thing that we're missing, I think, outside of, as a dentist or as a physician or, a specialist, a neurologist, any really practitioner that's seeing these patients is, let's again look at your neck. This screen is going to be under a minute. So again, moving your jaw. Now let's move your neck. Side to side, rotation, flexion, extension, and let's see how your upper back is moving. Again, the screen is designed to be quick because we're all busy, but we want to be able to find out if there's restrictions, because that's going to lead to, is the neck involved with the TMJ pain, and how is it, how is it affecting that? So that's a really good way. That's probably one of the biggest things that I want to bring out and give to you guys. The next one is going to be list and describe cardinal features of craniofacial red flags. So this is the other thing that I like to bring up, because if we're working with whatever type of patient population you're working with, you got to find out, hey, is this patient safe and appropriate for my care? Especially with craniofacial pain, because there's a lot of stuff going on here. You've got, obviously, brain is here. You've got all sorts of structures in the anterior portion as well as the posterior portion of the neck. And the TMJ, so there's a lot of things that we need to be on the lookout for craniofacial red flags in physical therapy, but really just in any field where we're screening our patients. So the next point I want to bring out is identifying the key points in managing patients with chronic symptoms. And I have kind of a hesitation to talk about chronic symptoms because I've seen so many chronic pain patients that do really well, and I just hate to label them chronic pain patients because, and I'm going to kind of talk about this a little bit, the more that pain science is evolving, especially in chronic pain, is saying that what we're saying to these patients and these people on an everyday basis, guys, they remember that kind of stuff. So if you're saying things, to give you an example, in physical therapy and in medicine in general, patient comes in with, say, neck pain, you're telling them that they have degeneration, arthritis, degenerative disc disease, permanent damage, nerve damage. Those types of verbiage, those things are not good for patients. Because I'll tell you what, I see patients every day that come in and tell me what their doctor said 20 years ago or what their dentist said 10 years ago, or even what their physical therapist said. So really learning to change our language as providers, regardless of your field. The research is starting to say that, hey, that stuff impacts how your patients, how your outcomes are, if they're going to get better, if they're going to get worse. That we kind of call it a thought virus. So it's a virus that is making them worse and worse, and that's one of the biggest things that I like to teach my students is you really have to watch what you're saying. So some of the key points in this is the concept called central sensitization. This is essentially a concept in pain science where if you've got pain in one area, let's take, say, the right side of the jaw, and it's chronic, what happens is you start to get sensitized to other motions. So if you just developed jaw pain yesterday and chewing on that right side hurts, say this goes unresolved for a year or two, now you've got constant headaches on that left side, you've got some neck pain, you're scared to go and do things, you're scared to chew, you're scared to talk, just because of all those, start to get centrally sensitized because your brain is starting to get kind of confused on what's good, what's bad, and if you should do anything. So the way I describe this to patients and to my students is, when you wake up at night and you're going to go to the bathroom, for example, it's all dark, you don't have any night lights. So what you usually do is you kind of go real slow. Sometimes you'll use the walls to kind of guide you to wherever you're going, because your brain is unsure if you're going to trip on a kid's toy, on a dog's toy, or you're just going to fall on a carpet. So that's kind of a good analogy in saying when your brain is sensitized, it's going to take normal things, even walking, chewing, whatever the activity that a person is having pain with, and it's going to be on the protective mode. So when your brain is confused, it's not sure if something's going to be good or bad, it's going to lock down and it's going to say, this is bad, let's protect ourselves, let's defend ourselves, because the nervous system doesn't want you to undergo any harm. And the last point is list what possible providers are involved. So this is a good one just because, as I think in TMJ dysfunction and craniofacial problems, physical therapists are not the first people that you think of, but we're definitely not, we're all important in this game. And at the end of the day, it's going to be what's going to be best for the patient. Is it going to be a multifactorial approach? Is it going to be, work with a dentist and get some sort of a guard, go through some habitual training as far as what habits you need to avoid and what things you should start doing, and go work with a physical therapist to find out what type of dysfunction you're working with. Maybe go to a specialist from there. There is a little research that says the more providers that you see when you have a condition, the worse that you're going to get. So you want to be a little hesitant if you're, I remember a couple of patients in my past that they've seen 10, 12, 15 different people, general doctors, specialists, general dentists, TMJ specialist dentist, and they're just getting 10,000 different opinions, and that often spills out to the patient's confused, they're upset, they don't know why they're still dealing with problems, and they're going to keep seeking care because they're just in pain. It's a kind of a human response. So I think that's a good list of some of the learning objectives. Again, TMJ patients are one of those types of patients that I love to work with, and I think that we can all kind of get on board and say, how can we help these people? And in my field, it's kind of cool because I have the opportunity where it's not an invasive technique, and I want to kind of share that knowledge and say, you have a patient from you, you're sitting in a dental chair, maybe they're coming in for a cleaning, you ask them if they've ever had any jaw pain, and just to give you guys some information as far as how to help them manage these patients and start to give you some tools, because what I often find is patients are going to their dentist or to their primary care physicians. If they're going to the primary care physicians, they're referred to the dentist. If they're a dentist, sometimes you get a night guard. Sometimes it's more a specialized treatment, but oftentimes these patients get lost, and they really do. They get a prime example is they get a night guard, and then they just say, see me in 6 months, see me in 3 months. So I want to be able to spread the knowledge that this stuff can go away in a matter of a couple of weeks. And again, it's not all patients, but I just want to spread the word and help as many people as possible, to be honest with you. So again, thanks for watching. Again, my name is Dr. Chad Schaefer, Chad Schaefer Physical Therapy. And if you guys have any questions, concerns, suggestions on objectives, please let me know. And again, thank you for your time, and have a great day.